Much everyone for joining, and today we are really excited to have Dr. Natalie Crawford join us. But before we dive into that, I want you to remind you about the educational objective of this seminar. It's to provide a forum for presenting and discussing the state-of-the-art research findings in HIV pathogenesis, virology, care and treatment, and provide an opportunity for ongoing enhanced communication and multidisciplinary collaboration among researchers across our 5 CFAR affiliated institutions and their partner organization. So today we are privileged to have Dr. Natalie Crawford, who is going to talk to us about the structural pharmacy-based intervention to reduce racial inequalities in HIV care. She's an assistant professor in behavioral, social, and health education sciences at the Rollins School of Public Health at Emory University. She's also the director of the Prevention and Implementation Science Core at the CFAR at Emory. Her research normally examines the impact of structural intervention in non-traditional healthcare settings on reducing racial inequalities in HIV among marginalized population. She has published over 70 peer-reviewed manuscripts, and we are really excited to hear what she has in stock for us. So, Dr. Crawford, it's your turn to take over.
Thank you so much for the introduction, and thank you so much to CFAR for the invitation to present to you all this evening. I'm very excited to talk to you a little bit about my work, which is really centered around structural interventions to reduce racial inequities in HIV. So just to outline my presentation today, I'm going to start by giving you a little background, which I'm going to breeze through because you guys don't need much of an introduction on racial inequities in HIV and risk behaviors. But then I really want to segue into the theoretical frameworks that are guiding the intervention approaches that I implement. And then I want to take you through sort of the last 15 years of my research program, which has really worked in pharmacies to reduce racial inequities in HIV via harm reduction and HIV prevention resources. So as you all know, racial and ethnic inequities in HIV exist. This is mostly driven by Black populations, specifically Black men who have sex with men. As you can see in this figure, Black men who have sex with men have been driving the HIV epidemic consistently since, for over a decade, and they outpace HIV infections compared to every other racial and risk group. Counterintuitive to what we would expect and what really makes our jobs harder is that sex and substance use risk behaviors haven't really explained these inequities. So there are a number of studies, and some of this is a bit controversial around risk behaviors, around sexual risk behaviors, but racial minorities, for the most part, we see lower sexual risk behaviors, as well as comparable or lower drug risk behaviors. So from the National Survey of Family Growth, examining the prevalence of condom use during last sexual intercourse in the past 12 months, we see that condom use is higher among Black women and Black men compared to both white and Latino populations. The estimated proportion of those who inject drugs in the United States by race ethnicity is about comparable between Black and white populations and slightly lower for Latino populations. But then when we look at injection drug use behaviors that would increase transmission of HIV, such as receptive syringe sharing, we see that those behaviors are lower among Black populations. And so this shows Black populations as the reference group, and we say that receptive syringe sharing is significantly and positively higher for Latino and white populations, as well as those who are categorized as other. And so we know we have a lot of promising behavioral and biomedical intervention strategies that would, in an ideal world, work to reduce these racial inequities and reduce HIV for everyone. However, unsurprisingly, we have unsustainable effects on the individual level, and we also have inequitable distribution by race. So we know that syringe access providers are disproportionately located in neighborhoods that are harder for Black populations to reach. We know that PrEP uptake is significantly lower for Black populations. HIV treatment is lower for Black populations, as well as hepatitis C treatment. So now moving sort of into the way that I think about interventions, I've really focused on more of a structural level. Most of our interventions have really targeted the individual. And essentially what that means is that we wait for people to become at risk, and then we try to throw all of our intervention strategies at them. On the other hand, what I'm arguing is that we really need a structural approach, which would mean that we are targeting the population and capturing people before they become at risk, right? And so by doing that, we are able to shift the population distribution, because then we make it so that people do not even become into the risk category for us to have to do an individual level intervention. So there are really 4 ways that we can target the structural level, and this is based on some of the work by Deborah Cohen. We can target the availability of services, and so that is our access. We can increase access and make it widely available for everyone, which is a lot of the work that I do. We could also tackle the physical structure, so making something more amenable to administration. So for example, we could shift oral PrEP to long-acting injectable PrEP. The social structures are policy. So we can reshape policy so that there is increased access, or there is a difficulty for people to not have what they need. One example of this is naloxone access in pharmacies. Another example is California's and a number of other states that have been expanding PrEP access via pharmacies. And finally, we could also increase or establish media messages that would then target a large swath of the population. And so what I'm really arguing here is that we have these exceptional biomedical interventions, really, really strong behavioral interventions, but we need a combination of all 3 approaches: behavioral, biomedical, and structural interventions to really move the needle and impact the HIV epidemic. And so structural interventions are those that are defined as those that target the economic, social, contextual, policy, or organizational level factors that have increased risk or protection against HIV. So what are we doing here today? What does pharmacies have anything to do with this, right? We normally think of pharmacies as those, as medication dispensaries. I think one of the positive things that came out of COVID, although COVID was horrible, and is horrible still, people are still getting COVID. But one of the positive things that came out of COVID was that we're really able to see firsthand, the general public is really able to see the ability of pharmacies to act beyond medication dispensing. And so what my work has argued for quite some time is that we can also really imagine and envision pharmacies as a way for prevention, specifically within HIV and the HIV realm. So this map shows, it's outdated, however, and CDC brings it up and takes it away from time to time, and likely because these policies shift often. But this is a map of which states have legislation that allow pharmacies to furnish syringes and needles to people who inject drugs without a prescription. I was lucky enough that the very first state that did this was New York in 2001. And I was lucky that I was in New York and working with the group that that had the opportunity to evaluate this. So now I'm going to segue into some of the work that we did to really begin to understand how pharmacies can operate in the HIV prevention realm. So the program that allowed pharmacies to sell syringes without a prescription in New York was called the Expanded Syringe Access Program. I worked at the New York Academy of Medicine with the group that evaluated this program. It started off as a demonstration project, allowing pharmacies to sell up to 10 syringes without a prescription. People who came in and bought syringes without the prescription were given a little flyer that had this logo on it, and it would notify if someone was stopped with drug paraphernalia, not drugs, but drug paraphernalia, that they were purchased legally and that they shouldn't be prosecuted for carrying syringes. What we found from this program, the evaluation of this program, was that it was a success. So pharmacy staff were supportive of this. There were increased reports of safe syringe use. There were no increased reports of improper syringe disposal. And the issue that people often have with these types of programs that expand access is that they think they're going to increase drug use. And there were no reports of increased drug use from this program, which was awesome. On the downside, we learned that this wasn't reaching Black and Latino people who inject drugs equitably. And so as a result of that, we implemented the Harlem Intervention Project. And this project was a community level intervention in Harlem using South Bronx as the control group. And essentially what we did was talk to people about drug use as a disease, give them information and knowledge about substance use, about the ESAP program, and really just try to work to sort of destigmatize substance use and highlight the need for access to safe syringe equipment. This intervention increased safe syringe use overall in the entire population by about 100%, but specifically among Black PWID by about 300%, so from 5 to 22%, which was still low. But one of the things that we learned from working with pharmacies at this point, and this is going to be a recurring theme in the few studies that I'm going to describe after this, is that pharmacists specifically kept telling us, but we want to do more. And so as a result of that, we developed the PAT-Link project, Pharmacies as Treatment Linkages. And so what we decided to do was to really train about 12 pharmacies in New York City on how to provide referrals for social, medical, and treatment to people who came in the pharmacy and bought a syringe without a prescription. So this study was largely successful. We were able to increase safe syringe use among people who injected drugs. In addition, we were also seeing increases in support for the ESAP program, for selling syringes to people without a prescription among pharmacies. And so their positive reaction to this study and this service for their clients was really, really encouraging for us. And we learned again that they kept saying, well, what else can we do? How else can we help people who are obviously going through a rough time in their lives? How can we help better shape their lives? And so we began to think, well, why don't we test this intervention a bit more rigorously? And so we developed a randomized pharmacy intervention. We enrolled almost 90 pharmacies with the goal of reducing injection risk among people who inject. We worked with a working group, which included healthcare providers, executive directors, and other staff from community-based organizations and people from the local health departments. And they really helped us work with the community to both develop and implement this intervention. So I'm gonna give a lot of information on this slide, so I just want to give you a little bit of a forewarning. This graph shows the pharmacy staff support among pharmacy staff support of the ESAP program among the pharmacy staff enrolled in this study. And we, remember I said we did a randomized intervention where we randomized pharmacies into one of three groups: an intervention group, a primary control group, and a secondary control group. In the intervention group, we brought all of the pharmacists and pharmacy staff to the New York Academy of Medicine over a course of a few nights whenever they could make it. And we essentially trained them on what substance use was, how to talk to people who were under the influence, how to build rapport with their pharmacy clients who were purchasing syringes without a prescription. We also furnished them with intervention packets, which included a booklet of all the social services organized by each borough in New York City, where their pharmacy clients could get information about where to take a shower, where to get a free meal, and any other housing or other social support that they might need. These packets also included some safe injection equipment such as tourniquets, rinse water, rinse caps, a fit pack, which is used for safe syringe disposal. So we did a pretty intensive intervention among this group. And then we also went back to their pharmacy to do walkthroughs with them on how to talk to their pharmacy, their clients who came in to purchase a syringe without a prescription, about our study, and to essentially schedule them for our study. And we would come in and interview those clients when they came back. So that's our intervention group. Then in our primary control group, we did not do an intensive training with them around harm reduction strategies, but we did go to their pharmacy to talk to them about, to teach them how to tell their pharmacy clients purchasing syringes without a prescription, how to tell them about the study, and they would also schedule them so that we would have a clean comparison, because we knew that the primary control group would have a tainted intervention effect. We also recruited a secondary control group where we only did surveys. So all of these groups received a baseline, a 6-month, and a 12-month follow-up survey. And so these are the results. This turquoise or teal line shows the intervention results. And over time, I want to point out one thing. You can see all of the pharmacies started off at baseline with pretty high levels of support, over 60%. Our intervention group had a slightly, the highest. As you can see, our primary control group, because they were having so much interaction with us, they reached the same level as our intervention group over time in terms of support of ESAP, which was almost 90%. But our secondary control group really had sort of declined over time. And so this is just showing that pharmacy staff support, even when they're asked to do a lot more, they are still feeling pretty positive about this program and the impact that it's making for their pharmacy clients who purchase syringes without a prescription. So for those pharmacies, for the intervention and primary control group who informed their clients about the study, and then we went in to do surveys with them, we asked them about a number of injection-related risk behaviors. And so here we can see the results of the PWID population, excuse me. We can see there is lower receptive syringe sharing among those who went to intervention pharmacies, almost significantly higher perception or use of pharmacies as their primary syringe source, significantly higher 100% sterile syringe use among the intervention, those who went to the intervention pharmacies, and lower pharmacy perception of pharmacies syringes as pharmacies as a barrier to purchasing syringes. So we thought these results were overall pretty positive. And again, the pharmacies in this study said, what else can we do? Can we do more to try to help the population? And so we thought, well, maybe we could implement some more HIV prevention services in pharmacies. And so we wanted to test the feasibility of HIV testing in pharmacies. We recruited 2 pharmacies in Harlem and had a really outsized response. We were really directing this towards people who injected drugs, but found that a lot of the community were coming in because they were hearing about the study and were just interested and wanted to get HIV tested. And this is a place, this is Harlem, where there were a decent amount of resources, but people still felt comfortable coming into a pharmacy. For the study specifically, we felt positive about the fact that we were able to reach individuals at high risk for HIV transmission, so racially minoritized populations, people who use drugs, people who weren't recently tested for HIV, and people who didn't have health insurance. But among those that we were really directing this for, there was still only 40% HIV testing uptake. And so we began to think, well, what is actually happening here? Why don't we see higher uptake? And so we began to think about the role of stigma in influencing HIV testing, and this idea of HIV exceptionalism, where HIV is a disease that's unique from others. And so, we know there are a number of evidence-based ways to reduce stigma. One is increasing access, and the other is through normalization of the behavior. And so we thought, well, we can increase access to HIV testing in pharmacies, but some of the ways that we could also normalize this is by combining it with tests that are not HIV. They're not sexually transmitted, but we can also explore some media messages. And so we recruited 3 pharmacies. We recruited 1 pharmacy, which was in our comprehensive arm. This pharmacy provided HIV testing. We also established a healthy lifestyles video where essentially we were modeling people coming in to get an HIV test, or people saying, you know, people being offered an HIV test with all of these other screenings, and people saying, yes, of course I'll get that. It's no different than everything. I want to get everything checked out, right? And so we were really trying to model this idea that HIV is not really different. It's a chronic disease, just like a number of other chronic diseases. In this pharmacy, we also offered screening for chronic diseases. So we offered glucose, cholesterol, and blood pressure screenings. Then in our second pharmacy, we only offered HIV testing and this healthy lifestyles video. And finally, in our control pharmacy, we offered HIV testing alone. The results of this showed us that we were able to increase HIV testing uptake among those by 60%, among those specifically who reported high HIV shame and blame. Excuse me. So among the population that really had high HIV stigma, we were able to increase HIV testing uptake. And so we felt really positive about these results as well. And unsurprisingly, pharmacies still said, well, what else can we do? Can we do more? And so this brings me to my current work, which is the Prep Up Pharmacy study. And the goal of this study is to really develop and test a model for same-day screening and dispensing of PrEP in a pharmacy. And so we started off this work with a lot of formative work to really understand logistical barriers and facilitators among all the key stakeholders involved in this work, or that are a part of this, that would be a part of this program. And then we took some time and refined the intervention that we thought would work. And currently we're in the pilot study. We're in the pilot phase of this study. I'm going to talk to you about some of the formative work. And unfortunately, just before we got to this pilot, COVID happened. And so we weren't able to actually get into the pharmacy because they were working on skeleton crews. So I'm going to talk to you a little bit about some of the things that we did in the meantime. So in our formative work, we qualitatively interviewed pharmacists and men who have sex with men just to see whether or not there was support for getting PrEP in a pharmacy. And what we learned was that there was strong support among both pharmacists and men who have sex with men. Both groups highlighted that privacy and confidentiality were important, particularly men who have sex with men. This is not surprising. Everyone wants their privacy surrounding their health. And then among pharmacists, they really asked a lot, well, how am I going to get my staff trained? Like, how do we do this? It was really important for them to know how to get the resources available for their staff. We also interviewed pharmacy staff because most of you all know, whenever you go into a pharmacy, the first point of contact that you normally see is the pharmacy technician. That's generally who's at the counter. You oftentimes have to request to see the pharmacist. And so we wanted to also get information from the pharmacy technicians on their level of support for this. The findings showed that there was strong support for screening for and dispensing PrEP in the pharmacy among both pharmacists and pharmacy technicians. Both groups were really concerned about training. And how they would get the training, what that would look like. Pharmacists felt very strongly that they could set up shop in the pharmacy as is, right? They had the infrastructure. As you guys have probably all seen, pharmacists are very clever with their space. They will pop up a little gown or a curtain and create a private space. And that's what a lot of them have done in COVID, even in very small spaces to be able to provide vaccines or tests. But pharmacy technicians didn't disagree that they could provide space. They had infrastructure concerns, but their concerns were really around what happens once I get someone who tests positive? Or how do I make sure I'm linking the patient with the right PrEP resource? So their concerns around infrastructure were really around, do they have the support and connections with the community to make sure they have a place to send their pharmacy clients? But both groups, pharmacists and pharmacy technicians, were willing to provide the service if they had the capabilities to do so. So because of COVID, we were unable to immediately start the pilot, and we, developed this model intervention that we wanted to test. So what we decided to do before we could get into the pharmacy was sort of do we wanted to see if we were able to implement the intervention, who would we get in the pharmacy passively? And would we actually get the risk group that we were interested in? So what we did during COVID was recruited 2 pharmacies, and we trained them on sort of a modified protocol of what our intervention. It's very, very watered down. So essentially what we did was talk to them about how to tell their pharmacy clients that there's a study going on, and they allowed us to put these posters up in the pharmacy. And we also created the same flyers that looked like this, and they put this in the prescription bags. And so in this little orange box, there was a QR code that individuals could screen with their phone and take and go directly to the consent form and the survey, so that they could answer questions about the survey. In just a 2-month period in these 2 pharmacies, we got about 460 people screened. And of those, they went on to a longer survey, because they were 17, almost 18% of those would have been eligible for PrEP because of what they reported as their sex or drug risk behavior. And we felt like that was really positive, that like almost 20%. This shows the demographic characteristics of that group that came into the pharmacy. And so there are just a few things that I want to highlight here. First is, we thought we were going to see a lot of sexual risk. We were quite surprised to see that there were a number of people also reporting injection risk in the sample. The other thing that we noted was that there was pretty high levels of a lifetime homelessness. Income was low, which isn't that surprising because of the neighborhood that one of the pharmacies was in. Although there was pretty high levels of college education in the sample. Promisingly, we did see really, really high willingness to obtain services in a pharmacy. So most people had filled a prescription in a pharmacy. A lot had received a vaccination or a health screening. One of these pharmacies is very active in the community and does community fairs sometimes in their parking lot. And so that could explain some of why these numbers are so high. But a lot of them reported being comfortable receiving a free HIV test, being referred to HIV testing by the pharmacist, had already received information on HIV, and a lot of them had already heard of PrEP as well. So there is growing evidence of pharmacies' ability to really operate across the HIV prevention and care continuums. This table shows a systematic review that came out of my lab last year in collaboration with some folks in Seattle, Elise Tung, who's a pharmacist there. And essentially what we did was looked at how many studies were published across the HIV prevention and care continuums. And so you can see there are most studies in pharmacies really tackle HIV testing and syringe access. There are fewer for PEP and PrEP. And then this final row, excuse me, this final row shows the risk population that these studies were conducted among. Notably, most of these studies have really been directed towards people who inject drugs. Some of the PrEP, including Elise Tung's PrEP intervention are among men who have sex with men, but we found that there was a gap in the literature on studies that really directed specifically to Black men who have sex with men, Latinx populations, trans populations, and Black men who have sex with men are really driving the epidemic. And so there's a big opportunity to learn more about whether or not Black men who have sex with men are even open to this service. And so we recently performed an analysis using data from the American Men's Internet Survey, and this paper will be published soon. My doctoral student, Daniela Lohan, is leading this paper. And what we saw in this is specifically among Black men who have sex with men, that about 77% of them are willing to be screened in a pharmacy for PrEP. And this is a nice, because this is a nationally representative sample of Black men who have sex with men. When we looked at whether or not there were any differences among this population for willingness, and we looked at this according to Anderson's healthcare utilization model, we see that there are really just a few things, which I'll say a little bit more about in a minute. High school education compared to less than a high school diploma, folks are less likely to be willing to be screened. But the biggest predictors of this, or correlates of this, are willingness to use PrEP in the first place and comfort talking to a pharmacy staff about PrEP. But notably, we didn't see any differences in employment or age or sexual risk behaviors, which are some of the things that we, sometimes see, and we felt like, well, this must indicate that more universally people in this risk group would be willing to obtain services in a pharmacy. So we've also begun to think more about the potential reach of pharmacies in the HIV prevention and care continuums. So this map shows some data that will hopefully come out from my lab next year. This is just a preview. And so essentially what we've done here is mapped the 5-year HIV risk per 100,000 per people for the metro area. This includes all of the ending the HIV epidemic counties in Georgia. And so as you can see here, the color gradient, the darker the color, the more HIV. And so most of our epidemic in Georgia, in Atlanta, is in the southeast and southwest areas of town. On top of this, we overlaid PrEP prescribing pharmacy locations that we obtained from PrEP Locator, which is a resource that anyone can use. It's a national resource to identify where PrEP prescribers are. These are noted by the yellow triangle. So you'll see here that we have quite a few in sort of downtown, in the downtown area, but a lot of them are then dispersed further northeast of our city. And then, so in our imagining of this, we decided, well, why don't we saw that, PrEP prescribers are mostly congregated in one area and otherwise sort of inequitably distributed across the city. There's an actual mismatch between where they would need to be, which is sort of here in the deeper areas of the southwest and southeast parts of Atlanta. And where the resources are. And so in our imagining, we decided, well, why don't we see whether or not there is more equity among pharmacy locations if we were able to expand HIV prevention resources to pharmacies. And each of these sort of bluish dots represent 3 pharmacies. And so you'll see that pharmacies are essentially ubiquitous across the Atlanta area, even reaching out to these sort of outskirt places where we see HIV incidence is really high. We did this for Georgia and every other state in the Southeast where we were able to obtain data on pharmacy locations from that state board of pharmacy. There are a couple of states that wouldn't give it to us, but this is the same story that we see for every other state in the Southeast. There's a mismatch of where the PrEP resources are and where they need to be. The PrEP resources are generally in a different neighborhood than where they need to be, where there is more HIV. And pharmacies are still ubiquitous in all of the areas. And so we should really be imagining how we could expand access and make it and increase access for PrEP and HIV prevention resources that would not create an inequitable distribution of these resources. So I don't want to leave you guys with thinking that there are not barriers or limitations of this work. So this figure is one that I developed that really just shows there are a number of multi-level barriers to expanding services in pharmacies that span from the policy, the community, the pharmacy, and the individual level. On the policy level, we really need to get boards of pharmacy on board with their recommendations for what HIV prevention resources should be offered in pharmacies in the South, is particularly in Georgia. They are not explicit, and why HIV is treated differently than any other disease that we can screen for in a pharmacy is unclear. On a community level, we all know the effects of stigma that make it difficult for people to want to obtain services or willingly obtain services. And so this is something that we really need to work on in our communities. And then on a pharmacy level, we really need to better understand how to integrate these HIV prevention, treatment and prevention activities into the workflow of the pharmacy, and which types of pharmacies work best for this. And so some of my future work is really going to work to build the implementation science evidence for integrating HIV prevention resources into pharmacies. I know a lot of you are doing work that is similar or along these lines. And so I would love to hear your thoughts around, sort of how we can figure out how to systematize this and scale this. So in conclusion, pharmacies are viable solutions to reducing HIV and substance use related harms. We could also conceive them as a way to sort of equal the playing field and increase access to resources that everyone should be able to reach equitably. And so some of my future steps are really thinking about ways that we can do that and how we can build the evidence so that pharmacies could implement this even in community settings where there are lower resources. Thank you for your time and for listening to me. This slide lists all of the collaborators that I have, all of the wonderful collaborators that I've developed in this work over many, many years now. I'd love to take any questions that you have. I think we have probably about 20 more minutes. 19 more minutes for questions, but you can also reach out to me via email or via social media. Thank you for your time.
Perfect. That was excellent. So